Hey folks, we're back. I'm your host, BKP, and we're at Circuit World here at Blue Ridge, Georgia. It's now time for Ask the Doc with Dr. William Whaley. We want to thank North Georgia Cancer Research, affiliated with Northside Hospital, so we appreciate Northside Hospital for bringing this segment to you. Dr. Whaley, we missed you last week, but we do want to say we really enjoy from time to time when Dr. Tidman comes in.
Did a good job, didn't he?
Yes, he did. Dr. Tidman did an outstanding job, and just really did. We appreciate him.
Did he have a joke?
Yes, he had a joke.
Okay, all right. But he didn't have the weather report.
No, he didn't have the weather report.
All right, I won't give the weather report. We're still 6 inches short on the rain, and global warming was associated with record low temperatures all over the South on Tuesday and Wednesday. So the global warming was associated with a really, really, really cold 2 days this week.
That was, we experienced a
Arctic blast.
Yeah, we experienced a global weather event. We have weather events, and I love.
It's crazy, isn't it?
Yes, we better move on.
It's crazy. Huh? So global warming was associated with a temperature of 18 degrees on my porch, and we had a really nice fire in the fireplace, and it's global warming. So go ahead.
We missed you last week.
Good.
I'm going to ask you. I'm asking you because I think they want to know, because I think it's very exciting. Where were you at last week?
All right. Last week was the 150th anniversary of college football games. The first game was played between Princeton University and Rutgers University. So in honor of the 150th anniversary, the NCAA sponsored a football game at Yankee Stadium with Princeton, who was one of the first two participants, and they played Dartmouth, my college. My brother Bob who's the federal judge, was behind me at Princeton by 3 years. And my senior year, Dartmouth was the Ivy League champion. His senior year, Princeton was the Ivy League champion. And last Saturday, Princeton and Dartmouth were undefeated. Princeton was number 12 in the nation in that division below Georgia Tech, and Dartmouth was number 14. Dartmouth beat Princeton 26-10, and Dartmouth went up to number 10, and Princeton went down to number 14. But it was a great weekend. We went to see Hamilton, and we ate in some great restaurants, and he had never been to Madison Square Garden, and we went to a 1 o'clock in the afternoon Sunday game at Madison Square Garden between the New York Rangers and the Florida Panthers, and my old Thrasher trainer was the trainer for the Panthers. I got a chance to visit with him before the game and go down to the locker room, and then the Panthers. Now if you're a hockey fan, he saw a goal that was called a setup goal. That's where you go down, bang, 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 and a pretty goal.
Right.
He saw a breakaway goal where a guy gets breakaway and comes down one-on-one on the goalie and scores. He saw a slap shot from the blue line that scored. The game ended in a tie, so he saw 3-on-3 overtime, sudden death overtime, which ended with a tie. This is the first year of 3-on-3, very exciting. So then he saw a shootout, and Florida won in the shootout. So those 5 things a normal hockey fan would have to wait a half a season to see in 5 different games.
I was getting ready to say that.
In one game, he saw them all.
You left one thing out.
What?
Didn't see a hat trick.
No, but he saw a fight.
Oh, okay, we'll throw that in.
He saw the fight.
That's kind of equal.
Right. All right.
All right. Okay, well, so after Dr. Whaley headed up to Yankee Stadium and over to the Garden, which some of you might say Madison Square Garden, over to the Garden, a hockey game, you made your way back to Georgia, where you thought it would be warmer, but it was not.
No, it was cold in Manhattan. It was colder in Atlanta. All right, go ahead.
Let's go to our first question,
Okay.
and we thank everybody for sending in questions. We'll tell you how to do that in just a minute. My mother had colon cancer 3 years ago and did 6 months of IV chemotherapy. Now she is concerned because her tumor markers, okay, in quotation, so that is something. I didn't know that. I'm learning something right there. Tumor markers are going up, and the doctors did not find anything on scans and repeat colonoscopy. Should she go back on chemo?
Basically, the answer is no. But it starts us into a discussion of tumor markers, which okay. Put up that first one there, Lonnie. You are real familiar with tumor markers, actually, so I'm going to explain to you why. This is just a cartoon of the body, okay? And BKP, you don't hear good, but you see good.
PSA,
all right.
prostate cancer.
All right, prostate cancer, PSA. Ovarian cancer, the CA-125, they say, should we do that test? Okay, they got one. Pancreatic cancer that's got its own. So this is the various common cancers: lung, breast, colon, prostate. Those are the normal ones. And colon cancer has a CEA. Now let's go back to the question. First, we know she had locally advanced curable cancer, or she would not have had that 6 months of chemo after her original surgery. Second, we know that at the conclusion of that chemo, she was in a remission with no detectable disease because they didn't do anything else. So she's now in a surveillance period where she comes back into the office. They do an examination. They do liver function tests. They do a blood test where they measure the CEA. So just think in your mind, because you know so much about prostate cancer, that they're measuring the PSA, okay, and it starts to rise. You've heard that here on lots of questions. But the deal is the CEA, okay, go to that next one there, Lonnie. If you look real carefully at this is a list of the tumor markers that you can get done in a commercial lab. But where it says CEA, right beside it, it says no specificity, okay? That means it's not like a thumbprint, the gloves don't fit, quit, that sort of thing. It's not a proof positive that the malignancy is returning. So if the CEA is beginning to rise, what they're going to do is they're going to do a very careful physical exam. And didn't they say they did a CAT scan or something there? Mm-hmm. And they did another colonoscopy to make sure there was nothing in there. So there's no detectable cancer. The question is, should she go back on chemo? And the answer to the question is no. But she should be very, very careful about continued surveillance and much closer follow-up. So they're going to stay all over her like a dirty show. Go to that next one there. It says blood tests. This is sort of the theory behind not only that one, but I mentioned there that the CA, I'll come back to the CA-125 for ovarian cancer in a minute. But this thing here on blood tests, now you've heard these two phrases a lot. What, that phrase?
False positive.
All right. And that one? False negative. All right. So falsely positive means it's elevated from some other cause than malignancy. Now, there's a laundry list of causations. Go ahead and put that last one up that says CEA, and we'll get off of this CEA in just a minute. But if you get, you have to have microscopic vision to read this long, benign conditions associated with elevated CEA. What's the first one?
Pulmonary
emphysema.
Emphysema. Pulmonary emphysema. Right, okay.
Okay.
Breathing.
All right, what's the next to the bottom?
Smokers.
So just think about how many people smoke, how many people have some degree of chronic lung disease. So if mama was a smoker and mama has got bronchitis or a worsening of her COPD, that might be the reason. She might have any of these other conditions, bronchitis, she could be having some diarrhea, right. All these GI things over here. And so there are lots of non-malignant reasons why it would be rising. So you certainly wouldn't put somebody, you can pull that one off and we'll leave them all off for a minute. You wouldn't put somebody on chemotherapy because they had bronchitis and their CEA went up. That's sort of the simple answer, right?
Right.
But you would bring them back in 3 months and do another set of liver function tests. And if the CEA is still up or going higher, you'd scan them again. In other words, you're going to stay all over this patient like a dirty shirt until you can say, the CEA went down, the bronchitis went away. So it's an indicator that you need to have much more close follow-up, but it does not mean that mother's cancer has come back. You got that one?
Right.
All right, so now we're going to get off of CEA. Let's go put up the next one, which is ovarian cancer. All right, now people keep asking the question about, and this was repeatedly questioned, should I have a CA 125 done to screen for for ovarian cancer? And the answer I give them 100% of the time is no. Go get a pelvic exam, have a pelvic ultrasound, but a blood test is no way to screen for ovarian cancer. So when you get over here to non-cancer causes, you've got everything from pleurisy, another one of these. I got a cough and pneumonia sort of thing. I've got an infection in my pelvis. I've got things wrong with my lung or my GI tract. And so the CA 125 associated with all these other things can be elevated so that if you're using it, you think you're using it to screen for ovarian cancer, it's going to lead you down a pathway that you don't want to go, where you're going to end up having a whole bunch of tests that may come to nothing, and it's going to give you a whole bunch of worry, and the idea is never do it. So now let's use it purely with somebody who had ovarian cancer. Now this is a much more specific one. If you have ovary cancer and your CA 125 is, say, 1,000, and normal is less than 35, and you get chemo, surgery, whatever you get, it goes down to 10, and then over time it goes from 10 to 20 to 100, then you probably do have recurrent ovarian cancer. That CEA, not that way. Now the last one we've talked about a bunch of times. We've had so much interest in pancreatic cancer because of, what's the guy's name, the Wheel of Fortune guy and all of that.
Alex Trebek.
Alex Trebek. Okay, so in the last 6, 8 months, 3 or 4 months, we've had 4 or 5 questions about pancreatic cancer. The marker, you remember, as a matter of fact, his headline was that his markers had gone up and that he was taking a week off to go back to get some tests. And then it said his disease had recurred and he was going back on chemotherapy. So here's what happened to him. His CA19 went up.
Right.
After he'd had his original treatment. He was up there, no, he wasn't spinning the thing, what Vanna White was, but he was on his program. And then they announced that his markers went up and he went back to wherever it is he's going to, and that they were starting him back on chemotherapy. Now, they didn't start him back on chemotherapy because the CA19 went up. The CA19 went up, they brought him back, and then they did some tests. Then they proved he had recurrent cancer of the pancreas, and then they started him back on chemotherapy.
Jeopardy. We might as well get that.
Jeopardy, is that what it is? Jeopardy.
Yeah, Pat Sajak's over there spinning him and Vanna. I didn't mean
anyway,
to interrupt you. But when you said that I have.
Okay, well, I'm way out of it.
I had to say
Jeopardy.
Jeopardy.
Yeah,
Go.
right. I'm way out of. I'm way out of. I watch.
No, I feel I got a question.
I watch Fox and Sports on television.
I feel I got a question right.
You got it right. You got it right. All right. So basically, this is a great question, but what it really tells you is, for families and patients, when you're being surveilled by a professional and the markers are changing, don't go jump off the Brooklyn Bridge, but stick with that increased surveillance until they say, yes, you have recurrence, and then let's treat it. But in this situation, the family should not say, oh my goodness, mama needs to be treated. It's got enough of that.
So, because I think when cancer, when we just say cancer, reoccurring, the tumor markers, I mean, some of us get into hurry up, we have to do something.
That's correct. That's right.
it's sometimes for us out here, it's hard to say cancer and patients in the same sentence.
But hurry up
You
and
know,
wait.
you know what right.
Yeah, remember hurry up and
Hurry
wait,
up
right?
and wait. So,
Yeah.
okay,
So,
I got it.
So what you want to do here is hurry up and wait.
Okay, we want to thank North Georgia Cancer Research, affiliated with Northside Hospital. We appreciate Northside Hospital for bringing this segment to you. If you want to send Dr. Whaley a question, you could send it to info, I-N-F-O, at fetchernews.com. Put in the subject line, ask the doc, and as he always says, the more detail that you give, whether you want to or not, age, male, female, I've got 3 kids. It doesn't matter.
Right.
Anything like that, you could drill down
I can.
with the answer.
We want the answer, right.
So number 2.
Now, while he's answering this question, Lon, put up that first one on the next one. It's you won't be able to learn what the question is by just seeing the picture.
Okay. My sister is getting over chemo for stage 3 triple negative breast cancer, and she is to get radiation. She wants to get reconstruction when radiation ends, but all the doctors tell her to wait. Some say a year, some say a while. What is best?
Okay, this is a complicated issue in that there has been so much publicity about mastectomy and reconstruction of the breast, and the poster child for that awareness is on the screen there now, and that is, who's this here?
I don't know her.
Angelina Jolie.
Is that who she is?
That's who this is.
I don't keep up with that.
Well, I don't either, except she was married to Jane's good friend, Billy Bob Thornton.
Yes, I remember.
And she has done as much by her open discussion of her condition to help with genetic testing for breast cancer, people going public with their families about what they're doing, and also the idea that you can be reconstructed and be back to a attractive woman. All right, put that next one up about the breast cancer reconstruction myths. The deal with her breast cancer was she did not have breast cancer. She had a positive gene for breast cancer. Remember that? Which treatment is taking off the breast. So she was not being treated for breast cancer. She was having prophylactic breast removal. So there was no chemo involved, there was no radiation involved, and they could carefully plan with plastic surgeons simultaneous reconstruction. So you're really talking about a period of one operation, big operation. Then you're talking about one period of recovery, which can be, let's say, she's wearing a bandage for 2 weeks and she's back to doing most things in 6 weeks, and she's recovered enough to play baseball or anything else in 3 to 6 months. So her as a poster child gets you aware, but it does not apply to these cancer patients. Okay, put up that myth thing there, because this is really, we're going to go down the myth side here for just a minute. It says you must wait after a mastectomy before you have breast reconstruction. That's the myth. Fact is, immediate breast reconstruction can be performed at the same time as mastectomy. That's true, particularly in people like her who didn't have cancer, or people who have early stage breast cancer that do not have to have radiation therapy and who had only hormonal or chemotherapy. Now, the issue about the radiation is that if you have the breast reconstruction, it is going to have to be done before radiation therapy. So you would have your chemotherapy, you would have your surgery, then you'd have a reconstruction, could be done at the same time, followed by the radiation. And we see, as oncologists, repeated episodes of patients who did it in that order, and then the radiation was delayed because of an infection or another complication, and before they can get the radiation, they've had a recurrence in the skin. So the timing of radiation in terms of treating the cancer is really crucial. The timing of the reconstruction is elective. Got the difference?
Yes.
Yeah, those dominoes that are treating you need to fall over in a sequence, and you don't want to pull that last domino out, which is radiation, and stick in reconstruction, because that reconstruction domino may have an infection in it and be way long, not short. So my advice to this patient is wait. Now, the idea of waiting a year is triple negative breast cancer, remember, is the most aggressive form of breast cancer we have, has a real high chance of recurrence, and you don't want to be going through reconstruction and healing of that when all of a sudden it's recurred and you've got to start taking chemo again. And after you've had radiation therapy, the field is not appropriate for planting. It's sort of fallow because of the radiation and the radiation skin change, and you are going to get a much better cosmetic result by waiting until the radiation has healed well, and that generally is a year. Okay, now show that next one there. We're going to do this kind of quick, and then we'll get into the news. But talking about reconstruction, this picture here, this is a patient who's had a mastectomy. They have enough abdominal fat to where they can make an incision and then roll that fat up there, and they are reconstructing that breast out of that patient's own tissue. This operation was invented by Carl Hartramp, who was an Atlanta plastic surgeon. He's now long dead. But that is the most common reconstruction done in the United States on patients who have a little bit of extra abdominal tissue, and most of our patients do. Go to the next one there. That's the breast reconstruction with the expander. This is what you're seeing done more commonly now in patients, particularly if they're a little bit lean at the time of their operation. And then right underneath the skin, they put a balloon type expander, and then you see that butterfly needle stuck in there. Then every few days or weeks, they put more and more tissue into that expander so that it stretches the skin and stretches the skin. Otherwise, that skin's flat, tight up against the chest wall until it's the size that they need for the cosmetic result that they're looking for. So lastly, we'll put up this last picture there that shows, and the title at the top of this says Drain Tubes from Hell ×4. This is not a simple operation. This isn't like going and getting your teeth cleaned. When they have this is that picture right there. That's the incision. You can see there's a mound here. On this side, they say expander and alloderm. In other words, they put some other stuff in there. You'll see two tubes coming out of that chest wall right there. You see those two tubes? Yes. They're draining this material under here. This is a process that goes on for weeks and weeks and weeks and weeks and weeks. And it hurts when you're expanding the breast with that tissue. You'll notice there's no nipple there. You can pull that down now so people don't have to watch it while they're eating breakfast. But then the reconstruction, after you've got it out to the size you want, and they got the implant the size you want, then you've got to make a decision about what else you're going to do. There's three things you do. Many people leave it alone because all you're looking for is the shape, looks good in a brassiere. It doesn't have to have a nipple on it. If you want to have a nipple on it, you can do that two ways. You can tattoo it so that it's just like you just got the tattoo on there so it doesn't have any form to it, or you can actually construct one out of tissue you take from other parts of the body. It's not important where you take it, and that then becomes another operation where you've got to build that up. So the breast reconstruction question sounds simple, kind of like you're going to go in there and it's going to be like cleaning your teeth, and mama wants to do it, or mama or sister or whatever it was wants to do it right now, and is there any reason why she shouldn't do it right now? I hope I've outlined that, first of all, you're treating cancer here. This is not an elective breast augmentation. So remember, this is cancer we're treating. Reconstruction's nice, but it's not part of the cancer treatment. So focus on the cancer treatment. If the cancer treatment doctors say do the radiation first, then this cosmetic reconstruction, although it's nice, should take a back seat to the cancer treatment. And lastly, it's not simple.
And we do have at the top of the question, this is stage 3 triple negative breast cancer, which you say
aggressive breast cancer,
which you say has high rates of reoccurrence.
Correct.
So the 1 year is somebody
not unreasonable.
It's not your doctor's not telling you and wait a while.
Yeah. Well, wait a while.
They have their reason.
They have a reason, right? Oh, well, first was I said,
and you don't want to go through that and then have a reoccurrence after you've done all
right,
that.
and you also don't want to go through that too early and not have a reoccurrence and have the radiation then make the healing bad and then end up with an infection. You can see how tight that thing is.
Yeah, it just looks.
You can imagine you could slough that thing in a heartbeat and that incision could get infected. So,
absolutely.
Yeah. So anyway, you don't want to follow the doctor's advice. Is basically what I'm telling you there.
Good question this morning. We appreciate all the questions you send for Dr. Whaley. Ask the doc. Send them to info@fetchyournews.com. Info@fetchyournews.com. Put in the subject line, ask the doc. Send that to us. Okay, so now we always at this time of the morning, we go into what is the most relevant, the newest thing, what's happening in the medical world out there today that you want to share.
Hey, Lonnie, did you hear what he said? What's the newest thing? I want him to read my handwritten note. What's that handwritten note?
Old school. We're going to go old school this morning?
Well, he started out with what's the newest thing. This is going to be really short. This is going to be like, if I say large, what do you think of? Or give me an opposite to large. Small, college boys. Right. So this is going to be that kind of thing. Here was the very first, at the top of the list of new medical news yesterday. Vaginal birth and breastfeeding reduce allergies and asthma. Now, we've known all along that breastfeeding was good for immunity, right?
Right.
And we've known all along that vaginal birth was safer than cesarean section, so both of those are old school, right? Okay. And this is an encouragement to these young people today to really consider that the way God made it was you had vaginal delivery and you breastfed your kids. And there are scientific reasons why that's the right thing to do. So that's an old school thing. All right. Now we're going to drop down here to number 3. And this was on the front page of a newspaper yesterday.
Progress made, but superbugs remain a threat.
Now, those are not bed bugs, are they?
No, I understand
superbugs are the infection that occur with badly antibiotic-resistant organisms that are responsible for more of the preventable medical error-type deaths than any other single thing. And you get that out there in the world when somebody asks the doc, I've got a cold, I'm getting ready to go on a cruise, can you call me in an antibiotic? So the short, what do you think of if I say high and you say low, is don't ask for antibiotics. This is the call your doctor, ask for antibiotic season, right?
Yes.
Flu season's just starting. Guys are getting a little congested. I think when I came in this morning, Lonnie's voice sounded like he'd dropped 3 octaves and his nose sounded like he'd been hit in the head with a baseball bat, so he's congested. Well, I told him, I said, it sounds to me like you need to get some Afrin and some nasal spray down at the pharmacy where somebody else might call a doc, say, I need a Z-Pack, or send me some penicillin or amoxicillin or something because I'm going on a cruise tomorrow. Tomorrow's Saturday, right? I need an antibiotic. So my short answer is don't ask for antibiotics, okay? Now we're going to go to the next page. We talked about this in your absence, and then we talked about this in your presence, and I believe you got an email from me in the middle of the night last night with a link to that one. What does it say?
Oh, yes, you did. I got up this morning, I'm checking my email, and I see new shingles vaccine. Yes.
Okay, now what does it say?
What you need to know.
98% is what they say in this article effective. I've been telling you 88 to 90% with no adverse reactions except injection reactions, just like you got anything else. 1 or 2% of people might get a sore arm or something like that. 98% effective, no significant side effects. Nobody thinks that this vaccine has any adverse autisms or anything else. Why? It's given to people that are over age 50 only. Take the new shingles vaccine, everybody. That's that last one. All right, here's the last one. And this one, this is going to be in the paper today.
Lung cancer report delivers bad news.
Good news and bad news. Okay, the good news is only 14% of American adults are now smoking.
Good news.
That's 30 million, however. The other good news is that the survival rates are substantially improving. So the new early detection test, we talked about that here about 3 or 4 weeks ago, which is the low dose spiral CT in people with a long cigarette smoking history, are detecting lung cancer at an earlier stage that is better cured. The bad news in that is that the huge population of people eligible for that test, which is over the age of 50 and have smoked a combination of at least 40-pack years. So that means a pack a day for 40 years or 2-pack a day for 20 years. Only about 15% of those people are getting screened. So if you were a smoker, if you're over 50, if you had at least take the number of packs a day you smoked, and if you're up to 40-pack years, you go ask Dr. Tidman or somebody to send you for that test. If you're smoking now, quit, don't vape. And if your kids are vaping, make them stop. But that's basically a good news report. And with that, we'll quit.
I got a quick question. Now, I know Rick's over there with some guys.
Marines. Hoorah!
All right. So, Rick's over there with some guys getting ready to come in. We got a great segment coming your way just a second. Tell me where I'm wrong here, because I only caught this in passing and did not get to really spend some time reading on it. Was there a lung transplant this past week?
Yes. On a vaping vessel.
A vaping?
Yeah.
Yeah.
Yes, bilateral lung transplant.
What is that? I mean, I know it sounds like, you just take the lung out and put it back, but what is it?
All right, it is. Actually, the lung's fairly easy to transplant because you think of the if you just look at a lung, you got to be able to hook it to the tubes. You got to be able to hook it to just a minor amount of arteries and veins. But some guys got to die on a motorcycle or got to die being shot in the head to be able to donate those lungs, right?
Right.
So a vaping patient with end-stage vaping lung disease had a lung transplant this week from somebody who had a motorcycle accident, got shot in the head. And lung transplants have not been around as long as kidney transplants, liver transplants, heart transplants. They're a little bit harder to maintain the rejection from because there's so much immunity in the lung. But I have a patient who was an airline pilot who had lung transplant 18 years ago and plays golf and does everything. He's not eligible to fly an airplane, but he does everything you and I do and has normal function, and he has not had any rejection problem with his lung transplant.
Dr. Whaley, I appreciate it. Again, Ask the Doc with Dr. William Whaley. I want to thank North Georgia Cancer Research, affiliated with Northside Hospital, for this segment. We appreciate you very much. Also, our YouTube channel, FYN TV, Fetch Your News YouTube channel. You find the playlist, Ask the Doc. The answers, the this morning. You can find them there. You can share them with family and friends. If you were watching this morning and say, oh, I know so many people that really need to hear the answers to these questions, you can find them on our YouTube channel. Again, FYN TV, Fetch Your News, playlist, Ask the Doc. Appreciate you very much. Send a question, info at fetchyournews.com, and put in the subject line, Ask the Doc. And we got to go because every year Rick puts this together and has a segment, and we're excited about this morning. We're going to tell you what it is. We got some great guys that are going to come to you and talk to you about Toys for Tots. And if you don't know what that is, you're getting ready to find out right on the other side of this break. What a great show we have today.
Yeah, and you got your expert panel to talk about that.
Oh, I got some. Yeah, you know who I have questions
about
for.
the peach pie, right?
Yeah, you know who I have questions for.
Impeachment pie.
Yes, yeah. Everybody, it's the ingredient everybody has to have. It's called impeachment, right? Take a break. We'll be right back.